Quality. Welcome to the culture of healthcare, quality measurement and improvement. This is part one of three. In our previous lectures, we focused on evidence based medicine, how research, data, and clinical expertise guide decision making in healthcare. Now we shift to the next essential step, which is quality. Quality measurement and improvement will be the focus of our final three sessions. Together, they complete the broader picture of healthcare culture and healthcare technology, especially from the perspective of clinical engineers. This component, the culture of healthcare, explores the expectations of professionals in the healthcare settings. It examines how care is organized within practice environments, the role of privacy laws, and the professional and ethical issues that shape the workplace. Quality measurement and improvement. The clinical engineering focus. Let's define healthcare quality and the major types of quality measures, structural processes, and outcomes, our outcome measures. And for clinical engineers, defining quality isn't just about patient outcomes, it's also about the safety, reliability, and effectiveness of medical technologies. Structural measures include the availability of certified, well maintained equipment, adequate staffing of clinical engineers, and accreditation of facilities, and process measures, which involve how equipment is used and maintained, preventive maintenance schedules, calibration, protocols, and staff training in device operation. And outcome measures for this particular objective, which are to capture the real world results, reduce device related errors, improve patient safety, and minimize downtime in critical systems. The second objective that we will be covering is to describe the current state of healthcare quality in the United States. So, clinical engineers contribute to the national efforts to improve safety and quality by addressing gaps in medical device performance and integration. So in the US, while there have been major strides in evidence based care and IT adoption, challenges remain in areas like interoperability, alarm fatigue, cybersecurity of devices, and variation in quality across health systems, where clinical engineering teams play a role in identifying and correcting these vulnerabilities. With that said, let's go ahead and get started on this uh, session. So, welcome back, everyone. In our last series, we explored evidence based medicine, how research and data shape decisions in healthcare. And today, we're stepping into the final stretch of this course, which is quality measurement and improvement. This is where all the threads have been following medicine, technology, ethics, and teamwork all come together. So, let's start with the big question: what exactly do we mean by healthcare quality? There are a lot of definitions, but one of the most influential comes from Avidus Donabedian, a true pioneer in this field. Back in 1988, he described quality as the kind of care that maximizes a patient's well being after you weigh both the benefits and the risk of the care process. It's not just about doing things right, it's about ensuring the patient is better off at the end of it. Another definition from an Institute of Medicine report in 1990 describes quality as a degree to which health services actually increase the likelihood of good outcomes and stay consistent with professional knowledge. So, in other words, care should be safe, effective, and up to date. Now, if you're thinking, where do clinical engineers fit in here? That's exactly the point. These definitions aren't just about doctors and nurses, they extend to the tools, systems, and technologies that support patient care. Think about it: if a ventilator isn't calibrated properly or if a monitoring system drops data, the patient's outcomes are at risk. And quality care depends on the reliability and accuracy of the technology just as much as it depends on the skill of the clinician. Let's fast forward to today. The 21st century costs are rising, but so are concerns about whether patients are actually getting the quality of care they deserve. That's why we've seen the push toward value based care. Instead of Paying hospitals and clinics based on how much they do. Reimbursement is increasingly tied to patient outcomes. So for clinical engineers, this means their behind the scenes work on equipment and systems now directly affects the hospital's bottom line. If devices don't perform, if data is inaccurate, or if systems don't communicate, it can literally cost the hospital money, not to mention the risk for patients. A national survey in 2014 predicted that within just 5 years, more than two-thirds of healthcare payments would be tied to value measures, and yet only a small fraction of organizations felt fully prepared for this change. And so, when asked what they needed most to make the transition, providers pointed to three things: tools to track and evaluate the quality of care, better communication between different providers, and a consistent definition of quality for specific diseases. And guess what? Clinical engineers are critical to all three. They are the ones making sure devices are connected and producing data that's both accurate and usable. And they're the ones ensuring communication between systems, bridging gaps between the infusion pump, a vital signs monitor, and the electronic health record are in compliance. And they're also the ones who help standardize measurements across different technologies so that quality can be compared consistently no matter the setting. The catch here is that even with all of these frameworks, nobody has a perfect formula for improving quality, but progress is being made. The National Quality Forum has published practices and performance measures that highlight the importance of care coordination. And here again, the role of clinical engineering is huge. Care coordination doesn't just happen between doctors and nurses, it also happens through the flow of technology. Imaging systems need to send results directly to the patient record. Monitoring systems need alarms that are accurate and reliable, not overwhelming and noisy. Devices used in the ICU or the OR or even the home setting need to provide consistent, trustworthy data. So, when we talk about quality in healthcare, we're really talking about a partnership. It's the collaboration between people, processes, and technologies, and clinical engineers are the custodians of that technology. They make sure that the backbone of care is strong enough to carry the weight of accountability, patient safety, and better outcomes. And that's where we'll leave it today. In the next part, we'll dive deeper into the different types of quality measures, structural processes, outcome, and explore how each one plays out in practice, especially when technology is involved. Donabedian's model of quality. So let's talk about one of the most important frameworks in healthcare quality, Donabedian's model. So Avedis Donabedian broke quality down into three main categories of measures. First was structure, then process, and then outcomes. The first category is structural measures. These are the foundational factors that either make it easier or harder to deliver high quality care. Think about things like where the hospital is located, how many patients it serves, or whether it's connected to a teaching institution. For clinical engineers, structural measures include the infrastructure of technology itself. Do we have the right medical devices in place? Are they up to date, well maintained, and properly staffed with engineers who know how to support them? Structural quality is about the environment we create for care. The second category is process measures, and these are about the actual activities of healthcare: what is done, how it's done, and whether best practices are being followed. For example, how many patients get preventive screenings or how closely doctors follow established guidelines. From a clinical engineering lens, process measures include how consistently preventive maintenance is performed on devices, how calibration and safety checks are carried out, and whether staff are trained to use the equipment properly. Good processes mean fewer device related errors and safer patient care. And then we come to the third category, outcome measures. And these are the changes we actually see in patients as a result of care: mortality, morbidity, recovery rates, functional status. These are all outcome measures. Clinical engineers connect here too because reliable technology directly influences outcomes. Think about a patient surviving a surgery. Outcomes depend not just on the surgeon's skills, but also on the performance of anesthesia machines, surgical monitors, and post op equipment. Donabedian also pointed out that these measures can be applied at different levels at the individual provider level, at the department level, at the organization as a whole. So for engineers, that means we can assess quality on the scale of a single device across an entire imaging department or throughout the hospital's entire technology ecosystem. So structure, processes, and outcomes, it's a simple model, but it gives us a powerful way to frame what quality really looks like in healthcare. And when you add in the role of clinical engineering, you can see how technology is woven into every layer of this model. Table of quality measures across levels. So on this slide, you'll see a table that lays out Donabedian's three categories of quality: structure, process, and outcomes across three different levels of healthcare: the individual, the department, and the organization. So let's walk through it. Structural measures are the foundation we build for care. At the individual level, that might mean whether a clinician or even a clinical engineer is professionally certified. At the department level, it could be whether there's appropriate staffing in the biomedical engineering department to handle preventive maintenance or urgent repairs. And at the organizational level, it could mean whether the hospital itself holds the necessary licensures and accreditations. These structural factors set the stage for everything else. Next, we have process measures. These capture what people actually do. At the individual level, they might involve performance evaluations or assessments of productivity. For a clinical engineer, that could mean how reliably they complete scheduled maintenance or how quickly they respond to service calls. At the department level, process measures might include how well a team is tracking safety checks or how closely they're following established guidelines. Say for calibrating imaging equipment. At the organizational level, processes might include the hospital's adherence to screening guidelines or system wide protocols for device integration. Finally, we come to outcome measures, the results that really matter. At the individual level, outcomes might show up in a practice profile, such as the number of errors made by a clinician, or for engineers, the number of device related safety events. At the department level, outcomes can be tracked in aggregate, like error rates in radiology or infection rates tied to equipment sterilization. And at the organizational level, outcomes include the big measures: mortality rates, patient satisfaction, and even regulatory sanctions if standards aren't met. Here's the key takeaway: quality isn't just measured at the bedside or in the boardroom, it's measured everywhere, from the actions of a single practitioner to the systems of an entire hospital. And for clinical engineers, that means their fingerprints are on every level of the table. The way devices are certified, maintained, and used feeds directly into how we measure, evaluate, and ultimately improve the quality of care. Processes versus outcomes. Let's dig into something really important in healthcare quality: the difference between process measures and outcome measures. Most of the time, when we measure quality, we're talking about measuring the process, how the care was delivered. Did the provider follow the steps? Was the guideline applied? Were the protocols checked off? But the real goal of healthcare quality is to look at outcomes. Did the patient actually get better? Was their safety improved? Did their health status change in a meaningful way? Now, here's where it gets tricky. Outcomes are not always easy to measure, and they can be influenced by things outside the control of the care team. A patient could receive flawless, guideline based process cares, but because of another health condition or a random complication, they may still have a poor outcome. So, is there a relationship between process and outcomes? Well, it depends. In some areas like acute coronary syndrome, research shows a strong correlation. The processes we measure, like timely administration of medications or procedures, are tightly linked to better outcomes. But in other areas, the link is much weaker. Take patient satisfaction, for example. Studies show that how satisfied patients feel about their care often doesn't line up with the technical quality of that care. One study in 2006 looked at older, vulnerable patients. It compared their perceptions of care with an objective quality assessment, and the result, well, patients consistently rated their care higher than what the technical quality measures revealed. And then there's the fact that the science itself changes. Diabetes care is a great example. Our understanding of what good control looks like has shifted over the years. As medical knowledge evolves, quality measures have to evolve too. Sometimes that happens quickly, sometimes more slowly. And sometimes there's no clear agreement at all. For example, there's a lot of discussion about which drugs should be avoided in elderly patients because of safety risks, but ask different expert groups and you'll get different answers. Reaching consensus on quality standards can be harder than it looks. And now, from a clinical engineering perspective, this distinction between process and outcome plays out with technology too. We can measure the process, how different equipment is calibrated, whether preventive maintenance is on schedule, whether safety checks are documented. But the real test is the outcome. Does that work translate into fewer device related incidents, safer surgeries, and better patient recovery? Just like in medicine, the link between process and outcome can be strong in some areas and weaker in others. So when we talk about quality, it's not just about following the steps, it's about constantly asking, did it make a difference for the patient? Now let's look at process versus outcomes. Let's imagine a patient named Mr. Ramirez admitted to the ICU with severe pneumonia. He's placed on a ventilator to support his breathing. And from a process standpoint, everything looks perfect. The ventilator was properly inspected that morning. The clinical engineering team had completed all the scheduled preventive maintenance last month. Alarms are set to the correct parameters. The respiratory therapist follows every guideline for intubation and ventilator management. On paper, the process is textbook. Now let's look at the outcome. Despite all of that, Mr. Ramirez still develops a complication, a secondary infection that has nothing to do with the ventilator or the care team. His outcome worsens, but not because the processes were flawed. This is why measuring only process doesn't tell the full story. A perfect process doesn't always guarantee a perfect outcome. Flip the situation around. Imagine a different patient, Mrs. Lee, Miss Lee, who is also placed on a ventilator. In this case, the process breaks down. Maybe a calibration check was skipped or alarm settings weren't reviewed carefully. And as a result, the machine doesn't respond properly during a sudden change in her breathing. And the outcome is directly impacted because the lapse in process led to a harmful event. So the key lesson is sometimes outcomes are poor, even when processes are excellent because of factors outside anyone's control. And over time, poor processes directly create poor outcomes. Something clinical engineers and then the entire care team need to work hard to mitigate or prevent. And that's why quality measurement always has to balance process metrics with outcome metrics because both tell us something important, but neither one alone gives us the whole picture. Measuring quality. So here's the bottom line. If we want to improve quality, we have to be able to measure it. One health policy expert, Dr. Landon, says, or he lays out a really clear framework for what good quality measures should be and what it should look like. First, they need to be based on the best available evidence. So we're not just guessing at what good care looks like. Second, there should be agreed upon standards for what counts as satisfactory performance. That way, whether you're a physician, a nurse, or even a clinical engineer, you know what's expected. Third, the measures need to be standardized. If different departments or hospitals are using different yardsticks, it's impossible to compare results. Fourth, you need a large enough sample size to make the data reliable. Looking at just a handful of cases can be very misleading. And because patients are complicated, often with multiple illnesses, different socioeconomic backgrounds, and unique circumstances, quality measures also need to adjust for confounding factors. Otherwise, we risk blaming providers or systems for outcomes that were never under their control. Landon also points out that measures should be attributable. That means that you should be able to connect them to an individual physician, a department, or a clinical engineering team. And of course, these measures have to be feasible to collect. If it takes more effort to gather the data than it does to actually provide the care, the system won't work. And finally, the measures should be representative. Maybe not every single thing a specialty does, but a solid sample that captures the real scope of their work. Now, here's where this resonates with clinical engineering. When we measure quality in engineering work, the same principles apply. Are maintenance procedures based on the best evidence for device reliability? Are there standards so every engineer knows the benchmark? Are performance logs standardized across the hospital so departments can compare? Do we have enough data points to be confident in failure rates or downtime estimates? And are these measures actually feasible to track with the resources we have? This brings us to a classic truth about quality. It all comes down to data. W. Edwards Deming, one of the great pioneers of quality improvement, famously said, "In God we trust, all others bring data." In other words, you can't improve quality based on hope, opinion, or assumption. You need real, measurable evidence. Or, as another saying from business management puts it, you can't improve what you can't measure. And that's the heart of this lecture. Quality improvement starts with measurement. If we can't see it, we can't change it. Pay for performance, value, and accountability. Let's shift gears and talk about some of the terms you'll hear a lot in the conversation about healthcare quality. The first is pay for performance, sometimes called P4P. Now, some people use the phrase quality assessment almost interchangeably with pay for performance, but that's not quite right. Pay for performance is just one approach to measuring and improving quality. The idea is simple. Providers and organizations should be financially accountable for the quality of care they deliver. So do a better job, get paid more. Do a poor job, face financial penalties. Of course, money isn't the only way to hold people accountable. There are ethical, professional, and even reputational pressures too. But financial incentives can be a powerful lever for change. Closely related to the term value-based purchasing, uh, think of this think of it as an application of pay for performance, but with the consumer in the driver's seat. Value based purchasing means patients or their employers make healthcare decisions based on quality. A patient might choose not to go to the hospital or a physician group if their quality ratings are low. Now, here's an interesting contrast. In almost every other industry, value based purchasing is standard practice. Car manufacturers evaluate the steel they buy based on quality. The food industry checks the quality of raw ingredients. But in healthcare, employers have historically been much slower to demand value for what they purchase for their employees. Part of the motivation behind today's healthcare quality movement is to change that mindset so healthcare is judged with the same rigor as other industries. Another term you'll hear more and more is accountable healthcare. This is the idea that providers and organizations aren't just accountable to regulators or insurers, they're accountable to patients and to the broader community that funds and consumes healthcare. Accountability means showing real positive outcomes, not just during treatment, but across the entire journey of care. And that brings us to care transitions. A care transition happens anytime a patient moves from one practitioner or care setting to another. For example, from the hospital to a rehabilitation center or from a primary care doctor to a specialist. Each transition comes with risks of miscommunication, data loss, or gaps in care. Quality care is about ensuring coordination and continuity. And finally, there's population health, which zooms out to the big picture. How do we improve healthcare across entire populations, not just for individual patients? Now, let's tie this back to clinical engineering. In a pay for performance system, if a hospital is penalized because of high infection rates, engineers play a role in ensuring sterilization equipment works flawlessly. In value based purchasing, if patients are choosing hospitals based on outcomes, The reliability of technology, imaging systems, infusion pumps, ventilators, and such become part of the hospital's competitive edge. And in accountable healthcare, engineers support care transitions by making sure data flows smoothly between systems. So when a patient leaves one setting, their device history and clinical information travel with them. So whether we're talking about performance, value, or accountability, clinical engineers are part of the invisible scaffolding that makes these quality initiatives possible. Now, when we talk about care transitions and accountability, let's follow a patient named Ms. Johnson. She's 72 years old and was admitted to the hospital with heart failure. After a week of treatment, her condition stabilizes and she's ready to be discharged. Not home yet, but to a rehabilitation facility where she can regain her strength. Now, this is where a care transition happens. Ms. Johnson is moving from the hospital to rehab, and along with her comes a set of medical needs. She's leaving with an infusion pump that will continue delivering her heart medication at a precise rate. And here's where accountability comes into play. The hospital is accountable for ensuring the rehab center receives not just the patient, but also complete and accurate information about her care and her device. That includes the pump settings, medication concentrations, and maintenance history. If that handoff isn't done well, the risk of error skyrockets. And this is also where clinical engineering plays a critical role. The engineers make sure the pump is functioning properly before it leaves the hospital. They verify the battery life, confirm alarm systems are working, and ensure the data from the device is documented in the patient's electronic record. When Ms. Johnson arrives at the rehab facility, the engineering staff there must also be accountable. They double check that the incoming device is compatible with their systems and confirm that their staff knows how to use it safely. Now, imagine what could happen without this accountability. If the hospital fails to document the pump's programming or the rehab team doesn't verify its calibration, Ms. Johnson's safety is at risk. The quality of her care depends on more than just clinical staff. It depends on the seamless coordination of technology, information, and people across the transition. And that's why in accountable healthcare, everyone has a stake. Physicians, nurses, administrators, and yes, clinical engineers, because true quality is measured not just within a single setting, but across the entire journey of care. What we know about healthcare quality. So, what do we actually know about healthcare quality? Over the years, a number of studies, reports, and national initiatives have tried to answer that question. One of the key tools that's emerged is benchmarking. Benchmarking is a management approach that helps organizations identify best practices, what works well, what delivers value, and then implement those practices at the best possible cost. In other words, it's about learning from the leaders and setting a performance bar that others can measure themselves against. In healthcare, benchmarking is especially important when it comes to quality activities. For example, if one hospital consistently has lower surgical infection rates or faster turnaround times for lab results, those results can serve as a benchmark for others to follow. From a clinical engineering perspective, benchmarking applies to technology too. Hospitals may compare device downtime rates, prevent maintenance completion percentages, or average response times for urgent equipment repairs. And the best performing organizations set the benchmark, and others learn from their practices, whether that's smarter scheduling, better training, or more effective use of health IT. So, on this slide, we've listed several of the most influential studies and reports that form the backbone of our understanding of healthcare quality. In the next slides, we'll walk through them one by one to see what they reveal, not just about where healthcare stands today, but also about where it needs to go. McGlynn study of quality of care. When we zoom out and ask how good is the quality of healthcare in the US overall, one of the most eye opening studies comes from Elizabeth McGlynn and her colleagues, published in the New England Journal of Medicine. And here's what they did. Researchers asked adults in 12 major U.S. cities to let them look at their medical records. About 7,000 people agreed. Then the researchers examined those records for 30 common conditions, things like diabetes, heart disease, asthma, and depression. For each condition, they checked whether patients were receiving care that matched the best evidence. Not cutting edge or experimental stuff, but the basics. The right tests, the right treatments, the proven approaches that we know improve outcomes. And here's the shocking result. On average, only 54.9% of the care patients received was consistent with best practices. In other words, patients were getting the right care barely half the time. And this wasn't evenly spread. Some conditions had higher rates of best practice care, while others lagged far behind. Now, what does this mean for us, especially from a clinical engineering perspective? It shows that quality gaps aren't just about medical decision making, they're also about the systems that support care. If a test isn't ordered because results from one lab system didn't transfer correctly into the electronic record, that's a technology problem. If a patient doesn't get the right treatment because a device was unavailable or out of service, that's an equipment management problem. The McGlynn study tells us that even with clear evidence of what works best, the system struggles to deliver it consistently. And part of closing that gap means making sure the technology side of healthcare is reliable, integrated, and ready to support the best practice every time. More insights from McGlynn and related studies. The McGlynn study didn't just stop at showing us that patients get the right care barely half the time. It also opened the door to some important follow up insights. One analysis looked at differences between socio-demographic groups. Interestingly, what they found was that the differences between the groups, say comparing one demographic to another, were actually greater than the differences within the groups. In other words, who you are and where you come from can matter more than the hospital you go to when it comes to receiving high quality care. Another finding was a little surprising. The quality of care actually increased with the number of chronic conditions a patient had. Now, why might that be? One reason could be that patients with multiple health issues are more likely to be monitored closely. They'll see multiple specialists and interact more frequently with the healthcare system. More contact points can mean more chances to apply evidence based processes. A similar analysis compared the national sample with patients in the Veterans Health Administration system. The results were striking. In the VA system, quality scores were higher for process measures, meaning they did a better job following evidence based steps of care, though not necessarily for outcomes. Given the VA's long history of being criticized for substandard care, this improvement was described as remarkable. And what's behind a lot of the transformation? A big factor is the VA's electronic health record system. By adopting EHRs early and embedding them deeply into their workflow, the VA was able to improve consistency, track processes, and reduce gaps in care. And for clinical engineers, there's a clear lesson here. Technology, whether it's EHRs, connected devices, or automated alerts, can play a major role in lifting quality. But it also shows the limits. Better processes don't automatically guarantee better outcomes. Just like we've discussed before, outcomes depend on many factors, some within the control of technology and providers, and some beyond. So the takeaway is quality improvement is possible even in systems with a troubled past. When technology is integrated thoughtfully, processes are standardized, and accountability is built in. The Commonwealth Fund Scorecard. Now, if the McGlynn study showed us the gaps within the US, another set of studies helps us look outward, comparing American healthcare to the rest of the developed world. Karen Schoen and her colleagues at the Commonwealth Fund have done exactly that. Their research paints a sobering picture. So, for patients with chronic diseases, the quality of care in the United States is no better, and in many ways worse, than what's provided in other developed countries. Their most recent national scorecard put numbers to this gap. If the US could match the lower mortality rates of just three other leading countries, as many as 84,000 fewer Americans would die prematurely each year. They would prevent them from dying from causes that should be preventable with good healthcare. And that's not just some statistic, that's tens of thousands of families losing loved ones unnecessarily. The analysis also pointed to massive inefficiencies in the system. For example, if we reduced insurance administrative costs to the level seen in other top performing countries, we could save about 114 billion every year. And Medicare alone could save 4.2 billion annually simply by preventing avoidable hospitalizations. So what does this tell us? First, that the US spends more and often gets less, and second, that there's a huge opportunity to improve both quality and efficiency by learning from the practices of other nations. For clinical engineers, this is a call to action too. So, preventable hospitalizations are often tied to poor coordination, gaps in monitoring, or breakdowns in chronic disease management. Devices like home monitors for heart failure and smart pumps for medication adherence and remote patient monitoring systems can help close those gaps if they're deployed reliably, integrated into healthcare records, and maintained properly. So the Commonwealth Fund's work reminds us quality isn't just a national issue, it's a global benchmark. And for the US to catch up, both people and technology have to work together to reduce waste, improve outcomes, and ensure patients don't fall through the cracks. AHRQ Quality and Disparity Reports. So, another important source of information on healthcare quality comes from the Agency for Healthcare Research and Quality, or the AHRQ. So, every year, AHRQ releases national reports on both healthcare quality and healthcare disparities. Now, what do these reports show us? The short version is yes, we're making progress, but it's still far from where it needs to be. Some indicators are improving, but others remain stubbornly, stubbornly low, especially when you break them down by region or by population growth. One really useful feature of these reports is how flexible they are. You can look at measures by specific indicator, for example, rates of hospital-acquired infections or timeliness of care. Or you can view the data by state, which means hospitals and policymakers can compare performance across regions. And that kind of benchmarking is a powerful tool for understanding where gaps remain. For clinical engineers, AHRQ's reports can be just as valuable. Imagine being able to see how your state performs on safety indicators like device related infections or preventable complications. That information helps engineering teams set priorities. Maybe more resources go into sterilization systems in one region or into alarm management and monitoring in another. And the key takeaway from AHRQ's report is this: quality improvement is happening, but unevenly. By making the data transparent by state, by measure, we can better understand where to focus our efforts, both clinically and technologically. Organizations driving quality. When we talk about improving healthcare quality, it's not just individual hospitals or providers working in isolation. There's an entire ecosystem of organizations, the public, private, and professional. They're out there and they're dedicated to raising the bar. So let's look at a few examples. First up is the Centers for Medicare and Medicaid Services Quality Improvement Organization Program, or QIO. This is one of the largest federal programs focused on improving health quality at the community level. The QIOs are independent, mostly nonprofit organizations spread across the U.S., staffed by healthcare professionals and quality experts, and their mission to strengthen care coordination across settings, hospital to rehab, clinic to home, and to transform healthcare delivery for Medicare patients, for clinical engineers. And this means making sure the technology side of care transition, like device data sharing and interoperability, works seamlessly too. Then there's the Healthcare Incentives Improvement Institute, or the HCI cubed, HCI 3. Their focus is on incentive programs tying payment structures to evidence based performance, and they look closely at health outcome measurements, preventable care defects, and ways to align provider payments with quality rather than volume. This is also where initiatives like Bridges to Excellence come in, which reward organizations for meeting higher standards of care. And for veterans, Quality Enhanced Research Initiative, or the Query QUERI, that works to translate research evidence into better care and clinical practices within the VA system. We already saw how the VA's EHR system contributed to higher process quality. So Query builds on that by connecting research directly to frontline improvements. The National Committee for Quality Assurance, or NCQA, maybe one that you've seen before. Their seal of approval is widely recognized. It's a good housekeeping stamp for healthcare. Organizations to use it, providers have to pass rigorous reviews and report annually on performance. So for patients and employers, it's a reliable signal that an organization is well managed and serious about delivering high quality care. We also have the National Association for Healthcare Quality, a NAHQ. And this is a professional membership and certification body for quality professionals across all care settings. And importantly, NAHQ is the only group that certifies certified professionals in healthcare quality, or CPHQ. For engineers interested in expanding their role in quality management, this is a pathway that's worth knowing. Another heavyweight is the National Quality Forum, or the NQF. They endorse measures that are evidence based, valid, and aligned with both delivery of care and payment reform. That, in fact, the NQF endorsement is often seen as a gold standard. So if a quality measure passes their review, it's considered trustworthy. And finally, the Joint Commission, best known for accrediting hospitals beyond accreditation, they also run the Key Quality Measure program, which recognizes top performers across the conditions like heart attack, pneumonia, stroke, asthma, and surgical care. And these measures are all evidence based and tied directly to accountability and patient outcomes. Now, this list isn't exhaustive. There are many more organizations in the U.S. and internationally, all working toward the same goal: better quality, safer care, improved outcomes. But specifically for clinical engineers, here's the connection. All these programs rely on data, consistency, and accountability. Devices and technology feed into those measures, whether it's monitoring outcomes, ensuring reliability, or enabling smoother coordination. In other words, engineering isn't on the sidelines, it's part of the infrastructure that makes these quality initiatives possible. Public resources for quality measures. So far, we've talked about the organizations driving quality improvement, but what about the practical resources, the tools that providers can actually use day to day? One important example is the National Quality Measures Clearinghouse, or the NQMC. This was a public resource supported by AHRQ that gathered evidence based quality measures and measure sets in one place. Think of it like library where clinicians and health systems go together to find standardized ways to measure care quality. Then we have CMS, the Center for Medicare and Medicaid Services, that provides a whole suite of or suite of tools on its website to help providers with quality activities. For instance, they have resources that explain the basics of clinical quality measures, what they are, how they work, and how many providers can track them. And they don't stop there. CMS also offers specialty specific reporting measures. So if you're in hospice care or cardiology or another specialty, you can find tailored goods for measuring and reporting quality in your field. So on this slide, hospice is highlighted as just another example, but it shows how targeted these resources can be. They're not abstract policy documents. They're practical guides that help organizations collect, report, and improve quality in real time, real quality data. So for clinical engineers, these tools are worth paying attention to. Why? Because quality reporting often depends on accurate, reliable data and from devices and health IT to conclude all that. So if the monitors, pumps, and imaging systems aren't producing right information, or if the data can't flow into the report system, the quality picture becomes incomplete. It becomes uh, yeah, incomplete. So engineers ensure that the technical foundation is solid so that when providers turn to CMS tools or NQMC resources, the data they're working with is trustworthy. So the big picture here is there are public accessible resources that make measuring and reporting quality easier, and behind the scenes engineers play a crucial role in making sure those measurements reflect what's in reality. What else we know about healthcare quality? So, what else do we know about the state of healthcare quality? Let's start with a powerful measure called amenable mortality. And this refers to deaths that could be prevented with timely and effective healthcare. It doesn't include lifestyle choices or accidents, it's strictly about conditions where good healthcare should make the difference between life and death. Two researchers, Nolte and McKee, analyzed this in a landmark 2008 study. They compared 14 advanced countries and ranked them on amenable mortality. The result, the United States came in last. Despite all our spending and technology, we were trailing behind when it came to preventable, avoidable deaths. That's a sobering reminder that having resources doesn't automatically mean delivering quality. Other studies have taken a closer look at providers themselves. So, for example, physicians who perform better on maintenance of certification exams also tend to have higher quality scores based on process measures. In other words, keeping up with professional standards and knowledge actually translates into better patient care. We've also seen that the use of hospitalists, doctors who specialize in caring for patients inside the hospital, is associated with stronger performance on hospital quality indicators. In primary care, two things stand out: the length of visit and the patient's sense of connectedness to their provider. Longer visits and stronger relationships both tend to lead to higher quality care, but the story isn't all positive. Research also shows that patients who are underinsured, minorities, or living with disabilities, or non English speaking often experience lower quality care in the primary care setting. And these disparities highlight the fact that quality isn't distributed evenly. It's shaped by social, economic, and cultural barriers as much as by clinical skill. Now, where does clinical engineering fit in? Amenable mortality often depends on timely access to effective technologies, whether that's diagnostic imaging, ventilators, and infusion pumps. If those devices aren't available, reliable, or properly integrated, patients may not get care quickly enough to make the difference. Similarly, disparities in primary care can be compounded if technology like telehealth tools or translation enabled patient portals isn't designed to meet diverse needs. So engineers play a role in making sure the infrastructure of care is inclusive, reliable, and accessible. So, what do we know about healthcare quality? Is it layered? It's it's about system level performance like amenable mortality. It's about provider performance like certification and connectedness. And it's about equity, who gets access to high quality care and who gets left behind. What we know about organizations and quality. We've looked at providers, but what about healthcare organizations themselves? Research here has been just as revealing. Take cardiac bypass surgery, for example. You might assume that if a surgeon trained at an institution associated with a best doctor rating, that their patients would automatically have better outcomes. But research shows that isn't necessarily true. Training pedigree doesn't guarantee lower mortality rates. The same goes for hospitals. Being listed on the US News and World Report's best hospitals list was linked with lower 30-day mortality for heart attacks. But here's the catch, some of those best hospitals actually had worse mortality rates, and many hospitals not on the list performed just as well or even better. In fact, three times as many non ranked hospitals had comparably low mortality. So reputation doesn't always line up with measurable quality. What does seem to make a difference? Studies point to organizations with direct leadership accountability for quality and safety and a culture of collaboration. Those places consistently show measurable improvements. Larger, more integrated subspecialty groups also tend to perform better on quality measures, likely because they can standardize practices and share resources more effectively. Now, how do patients or even professionals see this information? One tool is CMS's Hospital Compare website. So it's a website that compares hospitals. It's designed to help consumers make informed choices by providing performance data on hospitals across the country. You can select multiple hospitals and compare them directly across categories like patient survey results, timely and effective care, readmission, complications, and deaths, use of medical imaging, how quality links to payment, Medicare patient volumes, and some states also provide similar comparison tools. Other national efforts like the Hospital Quality Alliance and the Hospital Consumer Assessment of Healthcare Providers and Systems, or HCAPS, add valuable layers of data. And inside many hospitals, leaders rely on quality dashboards, internal tools that track performance and help guide quality improvement initiatives day to day. So, for clinical engineers, these dashboards and reporting systems are important too. Many of the measures, timely imaging, readmissions, complication rates, are influenced by technology. If a CT scanner goes down or an infusion pump isn't working correctly, that directly affects timely care. Engineers make sure the systems are reliable, the data is accurate, and the quality picture reflects reality. The bigger lesson here, quality isn't about brand names or glossy rankings. It's about accountability, collaboration, and systems that work consistently well. And increasingly, that system includes not just people and policies, but the technology clinical engineers help keep safe and reliable. Spending versus quality. So here's a question we hear all the time. Does spending more on healthcare actually mean better quality? At first glance, you'd think the answer would be yes. More money should buy more resources, more staff, better technology, and ultimately better care. But the data tells a different story. Medicare data shows there's a huge variation in costs among patients, yet very little consistent relationship to quality. In fact, one study looking at expenditures by state found something surprising. There was actually an inverse relationship between spending and quality ranking. In other words, some of the states spending the most money weren't delivering the best care. They were delivering worse outcomes. And it's not just one study. The National Committee for Quality Assurance, or the NCQA, publishes annual quality reports, and they also find no clear link between how much is spent per person and how good the care actually is. Even patients' perceptions of quality, what they feel about their care, don't line up with the dollars being spent. So, what's going on here? A big part of this comes down to efficiency and value. Spending more doesn't guarantee that money is used effectively. Sometimes higher costs come from administrative overhead, unnecessary testing, or inefficiencies in the system. And for clinical engineers, this insight is especially important. Hospitals may be investing heavily in new technologies, but unless those technologies are well integrated, reliable, and properly used, the extra spending may not translate into better outcomes. A poorly managed imaging suite or a fleet of infusion pumps with a high downtime could actually drive costs up while quality stagnates or even declines. The takeaway: more money doesn't equal more quality. It's not about how much we spend, it's about how wisely we use the resources we have. And that's where both healthcare providers and clinical engineers play a critical role. This brings us to the end of part one on quality measurement and improvement. So let's take a moment to recap. Healthcare quality is all about delivering the best possible care and making sure that care results in the best possible outcomes for patients. We explored the three major types of quality measures, first laid out by Donabedian: structural measures, process measures, outcome measures. So, structural measures were the foundation and resources that make care possible. Process measures were the steps and actions taken in delivering care, and outcome measures, the results that patients experience as a result of that care. And we've seen that in the United States, the current state of healthcare quality reveals a serious gap between the care patients actually receive and the care they could receive if we consistently followed the best evidence and practices. For clinical engineers, this gap is a call to action. Every device maintained, every system integrated, every safety check performed is part of closing that gap. Quality isn't just a clinical goal, it's also a technological one. So, in our next part of this series, we'll continue by looking at how these quality measures are applied in practice and what strategies are being used to improve care across different healthcare settings. Until then, remember, quality is not accidental, it's built, measured, and improved step by step.